Good morning, fellows from the East Coast, West Coast, and around the world. Welcome to our July Fellow Project lecture. This is the last one of your fellow year, so we're really excited to have a discussion with Dr. Renee Hilton and Dr. Darren Tishler. Before we get started for our talks today, Dr. Wilson, let us know what's going on with ASMBS.
Good morning, everyone, and hope you enjoyed your holiday weekend last weekend. Just for some announcements, congrats for all the fellows for making it to the end of the year. And just as a reminder, really consider your case numbers and completing all your documentation for your patient encounters, inpatient and outpatient, and your cases. Be sure to have that complete. And information will be forthcoming about the application opening for certification for bariatrics. So keep a lookout for that. To recap from the annual meeting earlier or last month, you can get your photos and headshots. If you get the weekly ASMBS updates, it was tagged last week, but your photos and headshots are available if you want that. There's also a recap webinar on July 23rd from 12 to 1 if you want a recap of the meeting. And also, again, President Richard Peterson, his initiative, No One Left Behind, and all his goals are also listed out if you want a reminder for that. And again, it's appropriate to congratulate Dr. Hilton-Rowe and Dr. Tishler on their service on the Access to Care Committee. They were Committee of the Year. And so appropriate to have leaders in the field today talking to us. Other reminders, registration is open for If So in Santiago, Chile, September 9th to 12th. Also save the date for ASMBS weekend. It's a more intimate meeting, great content and networking. That's November 13th through the 15th, and that'll be in Louisville, Kentucky. So save the date for that. In your community, if you want to host a Stop the Stigma walk in support of the Treo Foundation, registration is opening soon, and you can submit an application for that. And also the next bariatric happy hour is July 24th, 8 to 9 p.m. Eastern Standard Time. And I think that is all I have for the announcements.
Thank you, Dr. Wilson. So to start us off, we're going to have Dr. Renee Hilton speaking on healthcare policy and bariatric surgery. She's the section chief for minimally invasive and digestive disease surgery at Augusta University. She has been and continues to be the chair of the Access to Care Committee, our Committee of the Year, and has been instrumental not only in improving access to bariatric surgery and obesity care in Georgia, but nationally at this time. And then to round it out, we have Dr. Darren Tishler joining us. He's the division chief of minimally invasive and bariatric surgery at Hartford Health, and was a former co-chair and leader on the Access to Care Committee. He gets to take a break, which but has been instrumental for the last 4 years working side by side with Dr. Hilton. And he's currently the Connecticut ASMBS president, and he'll be focusing on getting a job in the current climate. So we're really excited for y'all's talks. Dr. Hilton, take it away.
Thank you so much. All right, I'm going to share my screen. Can you guys see me okay? All right, excellent. And it's not my presenter mode, right? It's just the solid screen. Good deal. Twice in one day, I'm on a roll. All right, so fellows, thank you for letting me come back. I'm going to be talking to you today about a subject that's really near and dear to my heart. It is truly where my passion lies. And I'm going to tell you a little bit about my journey getting here because I think that's important to understand it. But the title of this talk is Access to Care. I'm going to go through some terminology with you, the scope of the current problem. And I think the most important question I keep getting asked today is, am I going to have a job when I graduate in the current access issues climate that we're having with bariatric surgery? All right, so I've already kind of discussed the objectives. We'll fly through there. I think it's important to understand when people are giving you talks, everyone puts up these disclosure slides. I have no disclosures. I think probably the more important disclosure slide we should put up is why am I giving you this talk? Like, what expertise do I have in this field, and what makes me a person who should be, telling you how to do it? And So I'll tell you a little bit about my access journey because I've been doing this for a while now, and I truly love it. I love this quote by Harry Ecker. It's not enough to be in the right place at the right time. You have to be the right person in the right place at the right time. You have to have initiative, especially with advocacy work, to go out and make change happen. So I grew up in a little map dot in Southwest Georgia, a town of less than 1,000 people on a peanut farm. Went to UGA and then over to Augusta to MCG, down to the University of Miami in Jackson for general surgery residency, and where Rakisha and Darren and I were all of our Connecticut history started. I then went up to Yale for my fellowship. After leaving Yale, I came back to my medical school alma mater to really start and run their bariatric program. So, talk about being in the right place at the right time. I left Connecticut, which is arguably one of the most progressive states in our entire country in terms of policy, access, and just really great opportunities for patients. And then I moved down to Georgia, which at the time was arguably one of the worst states in the entire country. And you can see here when I arrived in 2017, Georgia was one of only 6 states lacking coverage. Over the course of the next couple of years, we were one of 3 states that lacked coverage for our state employees. And the reason that that's so important as a bariatric surgeon is your state insurance is usually a private or a commercial plan, and it is almost always the largest employer in your entire state. So when your state does not have coverage for all the people that work there, those are your firemen and women, your police officers, your school teachers. Just think about how many people in a workforce that affects. So that's where kind of being in the right place at the right time comes in. I've always been passionate about access, but I ended up here and just was appalled that this was a situation. So I said, what can I do about it? And that's really what started my access journey in Georgia, which has led to this national role. So I'm going to define some terminology for you because I think people use these first 2 terms interchangeably and they're not. Access versus utilization. Access is the right to obtain or make use or take advantage of something such as a membership, whereas utilization is the action of making practical and effective use of something. So what that really means for our patients is you can have access to bariatric surgery, meaning you have insurance that covers it, but are they actually utilizing it? And only about 1 to 1.5% of our patients do. So these are really, in my opinion, the 2 areas that access to care has to focus on. The other best analogy I like to use for access and utilization is my Peloton bike. I have access to it. It's upstairs in my workout room. Utilize that thing like once a year. So if you're trying to remember the difference, think about Peloton bike or your workout room. So some more terminology before I get into the meat of the talk. You'll hear this a lot of times as a fellow, and I think sometimes you guys may be a little scared to speak up and ask what these things mean because everyone tosses them around so common, but don't be afraid because this is kind of a foreign language if you're not in the space. One and done is a common problem right now in the access world. What this means is this is when an insurance provider says you can have one operation for your obesity your entire life, and that's it. So what that would mean is if you got a sleeve in 2020, maybe you went on, you developed life-altering reflux, or you had weight regain. Maybe you went as, you're female and you got pregnant, you had your first child and you had weight, you gained weight. We know that happens. We know that obesity is a chronic disease, but this insurance company says, nope, I paid for a sleeve back in 2020, no bypass, no SATI for you, no options for conversion. Even if they have complications from an operation, which again, I would consider GERD to be an undesirable outcome after a sleeve, we fight for these patients to get conversion. So again, that's why I use some of these terms together is they have access to bariatric surgery, but is it good access? That's not great access when you have really restrictive policies like one and dones. They'll also have policy exclusions. So what an exclusion means is they'll say you have access to obesity treatment. So the patient may think, oh, I have good obesity coverage, but then there'll be a little line in there that says bariatric surgery excluded, no room for argument, no flexibility, or they'll have expenses not covered. So they will basically cover portions of bariatric surgery, but they're not going to pay for the pre-treatment portion. So they won't pay for any of the RD visits, any of the pre-op, any of the post-op, any of the labs, or your copay for bariatric surgery is $10,000 out of pocket. But if you have a cancer operation, it's nothing if you've met your deductible. So there are lots of things that you hear us talk about where just because someone has access doesn't mean it's good access. These are the players that you're going to hear a lot about as you get out into practice and you start, wanting to do advocacy work. ASMBS, obviously, we are the organization for bariatric surgeons. The Access to Care Committee, Insurance Committee, and State Chapters Committee. If you have a passion for advocacy, these are the three committees where you can find your home. There are others that do plenty of access work, but these committees, man, we really, really focus on access and advocacy. Other organizations that are great are the Obesity Care Continuum, the OCC, the Obesity Action Coalition, OCAN, and those are all, you can all join those. Your patients can even join a lot of these. And then the last thing I would encourage you to do is join and donate to the Obesity PAC. I know you guys are fellows right now and you're not used to having any money, but that's about to change. You're about to get real jobs, and Dr. Tishler is going to tell you, how much money to ask for and all that stuff. But give some of it back to the PAC. The PAC does great things for us. That is your money at work. It's how we make changes in the legislation. I never understood how important that was until I ran Access to Care. When we need these lobbyists to go speak to people for us in DC, we have to throw money at them, guys. That's just how this world works. So what role does insurance play? So I've kind of told you who the players are, who the organizations are to join. Now I'm going to give you a little bit of the nitty gritty about how insurance actually works and what the big barriers are. So even though patients have insurance, why are they not getting to our office? Because I've told you utilization is a second part of this. Well, there's several barriers that have actually been pretty well published on, and a lot of it starts with their primary care providers. So our primary care providers, our friends and our peers out in the community, they still, even though it's 2025 and we have new guidelines and we are safe, they do not get what we do. They are still giving patients incredibly outdated advice, not all of them, but we've got to do a better job educating our primary, referral base. So when you look at a national survey of primary care providers, 53% of these providers believe that most of their patients could not afford the surgery. And it actually, when you look at this even deeper, most primary care providers believe that bariatric surgery is less effective than it actually is and more dangerous than it actually is. So they're telling these patients it's higher risk and less effective. So we've really got to educate these referral sources and go straight to the patient and educate them so they can really challenge some of the bad advice if they're being told it. And I've already talked a little bit about cost sharing, but that is a real barrier. If you have access to it and you can have bariatric surgery, but you got to pay $5,000 out of pocket, for most of my patients, you might as well say $50,000. $5,000 is too much money. So we have to do better with our referral patterns, and we have to do better with the cost sharing. The next thing you may hear if you join one of these committees are heat maps. We talk a lot about heat maps. And what that is it's a map that really gives you a good broad understanding of what the coverage is for our major payers. So Medicaid's a big one. Medicaid and Medicare cover bariatric surgery almost universally across the country. These are the exceptions. So if you're going to Montana or Mississippi, we need your voice. These are the last two states where state Medicaid does not cover surgery. Every other state does. State employees, I've marked off the three. The biggest win that we've achieved in Georgia in recent years is we got our coverage. I practice on the South Carolina River, so about 50% of my patients come from South Carolina, so that remains a huge elusive target for me. But South Carolina, Utah, and Idaho, and there are some pockets in other states where there are very select coverages, even within state employees that don't have it, but these are the big ones. And then this is probably our greatest target nationwide. This is what our Medicaid maps used to look like. This is our essential health benefit plan. Now, when the EHB came out, obesity was one of those diseases that was like one of the big 10. We have to cover obesity. We have to treat obesity. And it's listed as a disease that the essential health benefit plan will cover. However, it is up to every single one of these state exchange plans of whether or not they're going to cover it. And as you can see from this map, the majority of them do not cover it. This is a group of patients who, from a socioeconomic standpoint, they need coverage. These people probably need more help than a lot of our other patients in terms of their financial, the financial struggles that they're going to have getting to surgery. So again, this remains a huge target of the ASMBS, and I can talk to you, offline if you wanted to about some states that have had good success here. So access or utilize, again, we have a problem. I don't care if you say tomato, I don't care what you blame it on. 1 to 1.5% of patients eligible for surgery are using the benefit. And again, lots of reasons for that. I think that we are not even discussing it at a primary care standpoint. I think that the decision is being marketed to our patients as very risky with low reward. I also think we have a lot of competition right now. GLP-1s are everywhere. You turn on your commercial and you're going to hear a jingle about GLP-1s. So that has caused a dip in most of our practices. I will tell you nationwide, the numbers reflect about a 35% decrease in surgeries performed. I think we have reached the peak of that. And as most of us have gotten smarter in our practices about more comprehensive care, I do think the tide is turning, and we're getting a lot of patients actually excited with GLP-1s that are going to convert to surgery. So just again, another little bit of fact sheet about these patients is that insurers recover their cost in 2 to 4 years. So for a diabetic, it's less than 12 months. So if you're having this conversation with the insurance company and they're telling you it's too expensive, they're going to get their money back. It's a return on investment. 25% of your patients that are considering surgery are going to be denied 3 times before getting approval. Let that sink in. That means 1 out of 4 of your patients you're going to have to do peer reviews for. And that may not mean a lot right now as a fellow. When you become an attending, that is ridiculous. That is an absurd amount of our effort and our time that we are spending arguing with insurance companies instead of operating on our patients. So these prior authorizations and the complete arbitrary reason for denial, sometimes they don't even open the chart. That's another target of access to care. And about 60% of our patients are going to have worsening health during the waiting period. So another reason why these arbitrary rules of 6-month programs before surgery, they don't lead to better weight loss. They don't lead to better success. Our patients get sicker. And this is not just universally the same across all of our patients. This is a great study that showed racial variation. We have certain patient groups that are even more marginalized and have greater access issues than others. And you can see, from this paper, if you're Black, if you're Asian or Middle Eastern, when you control for everything else, even insurance, you are going to spend longer in a preoperative program to get to surgery than white counterparts. And so if you actually look at other studies, they can show that Black adolescent patients are way more likely than white adolescent patients to get denied, even if their charts were completely the same. They're more likely to get a denial. So that's more than access. That's a conversation that I think I could spend an entire lecture talking to you guys about problems related to marginalized groups and all the issues that we have. But there are clearly some things here that are bigger than just insurance. And you can see this in places like Canada. This is a Canadian paper where everyone has the same insurance. And despite that, you still saw disparities based solely off of race. And so again, this is more than an access problem. It goes deeper. So access in a perfect world, what does that look like? These are the 2022 guidelines. In a perfect world, this is what every insurance would follow because it's based off evidence and endorsed by ASMBS and IFSO. That's what we're aiming for. It's been another big push of mine over the past 2 years on access. So I joke, it's kind of depressing, right? Like the first part of my talk usually is because I tell you about all the problems. But now I'm going to tell you what we're doing about it and where we're winning. And I'm also going to issue all of you a call to action because we want you to help us. We want you to get engaged. Our mission for access to care, I'm not going to read it because it's lengthy. It's on our website. But I think that the last sentence really encompasses it all, is that ASMBS has a vision of elevating global health and quality of life by significantly reducing the impact of obesity and its related illnesses worldwide. And we do that by advancing our legislative and policy efforts. So current projects for the past year, just going to put these up there because I don't want to eat into Darren's time. We've had some big updates and new guidelines when we've obviously been attacking the employee health benefits. We're really trying to use our media partners and our communication committee to advance these things. We've had a lot of legislation efforts. TROA has been reintroduced again. We have addressed some major CMS issues. And then there's always local and regional policies. We've had huge wins in Louisiana and Arkansas by people like Phil Gotchison, one of my co-chairs, and Sam Bledsoe in Arkansas. I mean, these people have been sweating blood doing, grassroots movements, and it matters. They have made big changes. And then obviously my great friend Judy Chen, we have collaborated closely with our state chapters. This is what our people look like. These are my three amazing co-chairs that have worked with me the past 2 years. Darren and I have actually worked together for 4 years because I was a co-chair with him before becoming chair. These are all of our state stars and our regional superstars. So if you're about to go get a job in one of these states, these maps are in our toolkit online. I would encourage you to look at it, connect with these people, ask them, what can I do in my state? These are my two oncoming co-chairs. They'd probably kill me if they knew how big of these like blow up pictures I found online of them. But this is Dr. Shaina Levy and Dr. Joe Green. They are going to be taking over as my co-chairs. Don't win Committee of the Year or your tour gets extended. So President Peterson called me and asked me to do another year because we need to train a replacement for me. So I'm going to actually be doing my 3rd year's chair. And hopefully after 1 year, it's normally a 2-year commitment. After 1 year, either Shaina or Joe are going to take over for me. We have an awesome webpage and toolkits that were revitalized this last year. I've included the website for you guys. If you're a member, you have access to this. Go check it out. Especially these 2 industry-sponsored dashboards. When you get out into practice, if you don't have someone verifying insurance for you and you're like, man, I have no idea who has coverage, use this. Get someone in your office trained on this that can use it. We actually have an Advocacy 101 free resource on our webpage now where you can take an advocacy course, and I actually demo how to use these dashboards in that video. You can watch me show you how to walk through it, and then there's a user guide for both of them. But this will let you narrow down every insurance policy by state, what they cover, what their restrictions are. And the second one, one's done by Medtronic and one's by J&J. These are independent dashboards. It's not ASMBS. You'll have to check off the disclosure when you click on it. But the J&J one even gives you a restrictive score. So if you're going to your state capital and you're trying to say, you know what, I'm in Texas and holy smokes, blue of Texas is really bad, show them. You guys have a restrictive score of 20 versus over here in our neighboring state in Idaho, theirs is way better. They have a score of 5. So it's a little bit of objective data, which we like, that'll help. We are winning. I know I said I was going to cheer you guys up. Over 140 million lives are covered under our new guidelines, and 48.7 million lives now are covered for SADI. And that is nothing more than the hard work of people emailing and browbeating these medical directors to adopt our new guidelines. And again, why does your work matter? This was, you can see 120 million lives. This was 2 years ago. So we keep ticking these numbers up. We had a great CMS response they were trying to remove our procedures from the inpatient only list, and we blocked that. And that was, again, just from grassroots movements like this. So join your state chapter, donate to your PAC, email your reps and senators, join your state capital days, join the ATC. Please attend the meetings. Weekend is the most undersold meeting of the year. It's my favorite. Don't tell anyone. I much prefer it to week. I cannot wait to go drink some bourbon in Kentucky, amongst other things. Please come join us for the weekend meeting. It's going to be a lot of fun. And we have a great advocacy summit with state chapters that me and Judy Chen have put on for years. There's going to be roundtable discussion this year, and we can really teach you how to do advocacy over the course of the day. And then lastly, if you join us, you get to go do cool things like this. This is me with the leadership last year in DC. I got to go to the White House and meet with the Biden Domestic Policy Administration. I literally looked up and I was outside of VP Harris's office. These are cool things, guys. Through our organization, you have the opportunity to really make big things happen and impact change. That's our recent Hill Day in DC. We took 160 people to the Hill. It's the largest Hill Day we've ever done as the ASMBS. So will you have a job when you get out? Yes. We are not going anywhere. I think our specialty is actually rebounding right now from the challenges of GLP-1s. I also think the climate, when you start advocating and doing access right now, these insurance companies want to cover us. We are the cost-effective treatment right now because if you look at a one-time cost of $15,000 to $20,000 versus lifetime on GLP-1 medications, We just had an amazing study come out that my friend Shaina Levy's been on the Today Show showing that we are 5 times more effective than medications. There is no more gold standard for the treatment of obesity than bariatric surgery. You will have a job. Darren is now going to tell you how to get a good job and how to get paid for it. My last piece of advice for getting a job, though, is don't just limit yourself to bariatrics. You can do that, and that's fine in some practices. What I have learned is me being a little bit diversified and doing ab wall along with foregut, it really floated me this past year when my bariatric times were a little tight. My foregut volume was higher than ever. So my bottom line didn't hurt too much because I was able to do other things. And so that is the other thing I would tell you. Just diversify yourself a little bit, especially when you first start. If 10 years down the road, your bariatric practice is booming and you want to narrow it down completely, great. And again, this is purely my advice. Other people may completely disagree with me. But I like the fact that I'm a little diversified and can do more than just one trick. So that's it for me. I'm going to unshare so that Darren can take over.
Thank you so
Thank
much,
you.
Dr. Hilton. Dr. Tishler, take it away.
Share my screen and I'll just ask, are you seeing my screen here? Okay, beautiful. Well, good morning, everyone. I'm going to kind of link together a little bit about from what Renee said. I agree with everything she talked about today. And I'm going to explain why it's kind of very important for what we do. So I'm going to talk to you a little bit about employment contracts. Why do we need a contract? Who does an employment contract benefit? I can't tell you what Renee said was that how to get the job, but I'll tell you how to work through the process of it. And then you might ask how much of my contract is really negotiable, especially in an environment where there's a downtrend in surgery. And then I'll talk about a little bit how often I think about my own contract. And then another topic to think about is there really a difference between an academic and a non-academic contract? So the first thing you have to ask about and really understand is, where does the money come from? Well, it comes from your professional billing and the money that gets collected. Okay, but there's two parts of this. There's the dollars that come in to you professionally, but also the dollars that come into the hospital. And this is where our access to care committee is actually so important, because one of the changes that's been going on is a shift of cases from the inpatient setting to the outpatient setting. Now, we don't do anything differently in how we take care of our patients. What's changing when it's designated as outpatient is your patient didn't stay 2 midnights, therefore it's an outpatient case, and your hospital is going to get paid at a lower rate. And that money is very important, because those dollars that come into the hospital and the dollars that come into your practice is what drives what you're able to do. Now, healthcare systems and hospitals run medical practice at a loss. They may look at it as an investment per provider that's based on downstream revenue. And the hospital side of things, okay, so the dollars that come into the hospital are much greater than the dollars that come into the practice, okay? Real important to remember that. The big money comes in from the surgeries, from what happens at the hospital side, not in your personal practice. This will become very clear probably on your first or second day of doing cases as an attending. The trickier part is hospitals and healthcare systems are terrible at sharing this data with you. Hope nobody from my hospital is listening to this right now. And this is why Dr. Hilton's lecture was so important, because the more that we can help maximize the reimbursement, the better it is. Now listen, I don't think about reimbursement all day long, okay? I'm not one of those doctors that thinks about every dollar that comes in. I like to take care of patients. I like the connection I have, but you have to think about it sometimes. So like I said, that hospital reimbursement allows for all those nice things that we have in our practice. What do you need to do bariatric surgery? Body composition scale, dietitians, patient navigators. You'll learn very quickly about the MBS CRs, your coordinators, behavioral health providers, and the funds you use for research. It's an expensive venture doing bariatric surgery, and there's a lot of niceties that we have, but we want to be able to keep that. And that's why that reimbursement is so very important for us. So when you have an employment contract, what builds that up? Well, there's going to be, and I'm going to breeze through this stuff. I apologize, because I want to get to the questions and answers also. There's going to be a job description that should be pretty self-evident. It's going to state in your contract how much you're going to be compensated for what you do. What are the benefits that go with it? It's going to be some clauses about professional liability coverage, contingencies that get tacked on, which is non-solicitation, non-compete, meaning if you leave, you can't just take all your people with you. There may be some requirements of medical staff memberships and certain certifications, such as your board certification, et cetera. There'll be a section in your employment contract about term and termination. So how long is the contract for, and what happens if we don't have a contract anymore? Assignability, it means that if someone else buys your healthcare system or your practice, that they take over your contract for you. And severability, what happens if things dissolve? What happens if the healthcare system is insolvent? What happens to those contracts? There's usually a section on policies and procedures for your hospital or your group. And these are usually non-negotiable. And it's the modern form of a contract. There's a big section that just everyone has this, everyone has to agree to it. So those are things like the benefits that are provided. Your employer may give you rights and responsibilities about malpractice insurance. You have to carry malpractice insurance, or they provide it for you. Billing policies, you have to submit your coding for your cases within 24 hours. Physician responsibilities, representation. This is really important, okay? This is, if you don't have a license, you don't have a medical staff membership, you don't have insurance, you're not working. So it's so important to keep up with all of this documentation and really make sure you have a safe, secure place to keep these this information, because it can give you headaches at times. There'll be a section on confidentiality of the contract. You're not allowed to share contracts with other people. And what are the rights to intellectual property? And then there'll be sections about termination in the contract. Restrictive covenants is a term you're going to hear about where you can practice if you leave your current employer. And that's really dependent on the state. In some states, restrictive covenants are completely illegal. Some states have regulations on it. Some don't have any restrictions on restrictive covenants. Now, I'm going to breeze through these right here. There's various ways that you can be compensated. So, the most, this one is kind of a little archaic here, but it is used a bit here. But it's a straight salary or base salary with a bonus. What the good side's about it, it's consistent income. You know what you're going to make. But because it's a straight salary, if you're a highly producing or a busy surgeon, you're going to feel that you're unrewarded for that. Income guarantee, I think this is kind of going away a bit here, but you'll still see it somewhere. When you get those postcards and advertisements about a great healthcare system, near a major urban area, these are what this model is usually here, and it makes it look real good to a new provider. It gives financial stability, but these income guarantees go away at a period of time, 1 to 3 years later, and so there's a big pressure to make sure you're meeting certain metrics to get that income in the long run. Production-based compensation models. This is really kind of the model that most people follow today. It rewards work, okay? So you'll hear about RVUs. There's a certain work amount assigned to every single procedure that you do by CMS. And then there's usually a dollar-based conversion factor for those relative value units. These kind of models reward you for the work you do. There's also a good pressure to maintain that volume. And sometimes it may make it a little unclear about how much you should spend on focusing on quality rather than just the quantity of the work that you do. Some other ones, revenue less expenses. This is a little bit older model where it rewards your controlling your expenses in your practice. This works well for primary care. It doesn't work as well for surgeons. This one is kind of the socialism model, where everyone in a division gets exactly the same. It does foster a collaborative environment. However, when someone is not collaborative, these models fall apart very quickly. So you're just going to watch out for the type of compensation that you're being offered and really think about that. What makes up clinical compensation? So you'll take your work RVUs you generate, multiply it by a conversion factor, and that equals your clinical compensation. So an example, if you generate 5,000 RVUs per year, kind of like an average number, and the conversion factor is $50, your clinical compensation is $250,000, and multiply the two together. There can also be caps or ceilings or bands or variable RVUs, conversion factors. meaning that they're only going to pay you $500,000 a year. That's the highest you can get to. It's not a fair model, I don't think, but it does happen. It's a way of healthcare systems controlling physician employment expenses. There can also be a floor, which is good, meaning that your compensation will not go below a certain level. That provides some stability. Clawbacks are a little scary because if you're getting a set payout of your compensation and you don't produce the work, signs they can be a clawback of compensation in future years. Now, there's going to be terms about base salary adjustments, how often that your base pay is adjusted. The less frequent means the more stable your job is and the more stable your financial planning can be. Now, some people say, oh, I don't have a conversion factor. They don't pay me on RVUs. They really do. So let's give an example. You get paid $350,000 a year and you produce 7,500 work RVUs. Your conversion factor is $46. If you produce 2,000 RVUs, you got paid $175 per RVU. Still getting that same $350,000. So why is this important? We'll get to that in a second here. So compensation looks at your work productivity, your non-clinical compensation, performance bonus, if that's there, quality bonus, generates your total compensation. It's just an example I'm throwing out there. And then there's fair market value. If you haven't heard this term, you will hear it someday. We're in a specialty or a profession that is highly regulated, and there's certain laws like the Stark Law and anti-kickback statutes that basically state that you can't be incentivized by a healthcare system to bring patients to that healthcare system. What does that mean? If you're being paid a lot more than anyone else, someone's incentivizing you to bring patients to that organization. And so fair market value is the way that these that your compensation is going to be evaluated. And there's a lot more reading you can do on these topics. Just want to introduce them so you say, oh, I heard that topic before. Different specialties will have different fair market values. Your location will affect fair market value. Different parts of the country, you just get paid differently. Your experience, the more experience you are, typically is going to earn you a higher compensation. Different types of practice may determine your fair market value. And like I said, it's crucial for a lot of government regulations. Benefits should be in any contract. Don't forget the 401k. If there's a match from your employer, that's free money. You cannot refuse the free money. You want to see that you're getting paid for CME, continuing medical education, your licensure, life insurance, disability, tuition reimbursement sometimes is included in the benefits package. Loan repayment may be included. Some of the myths about contracts: protected time exists. Every single person who interviews with me for a position wants their protected time. Protected time, no one knows what that really means, okay? We all have an idea of what it is. If you're going to do research, you're going to do administrative responsibilities as a surgeon, you're doing it early in the morning, you're doing it in the evening. You're not going to sit down in the middle of a clinical day or an OR day and do administrative work. Another myth: there's the same amount of pay for time spent, doing these protected time activities like teaching or administrative responsibilities. No way. You will always generate more income by being in the OR and doing procedures than you will during any administrative time that you have. Another myth: I have an expensive lawyer. I just spent a couple $1,000s for a lawyer to negotiate my contract. I'm going to get more. No, you really don't need an expensive lawyer for contracts, especially since most of the contracts by a employed healthcare system are going to be exactly the same. There's very little to negotiate in them. Another myth you have to keep in mind: am I getting the same contract in terms as everyone else? It may not always be the case. Look into that. Ask the question. You got to ask this beforehand, because once you're entered into a contract, you're kind of bound by that contract. Another myth: I am not replaceable. Everyone is always replaceable to a healthcare system. Every time I hear horror stories of people who threaten, well, you can't replace me. And within about 5 minutes, the CEO of the hospital is replacing you. So a warning to you: do not threaten to walk or resign unless you are absolutely prepared to do so. This is one of those things that just no one ever teaches to surgeons. Well, I don't get this, I'm going to go get another job somewhere else. And they're going to say, okay, there's a lot of GLP-1s out there today. good luck go finding that job. So, just make sure you're prepared to do something if you threaten to do something. And please do not go into negotiating a contract with the intent of leveraging another contract. This is something we figure out real fast, okay, when we're trying to hire someone. When you waste everyone's time interviewing because you want to see what we're going to offer, so you can go back to your employer and say, hey, they're giving me this much more. It's never a good move for the long term. It will come back to bite you someday. So with your own personal finances, when you look at your dollars you're going to get for your first contract, don't forget taxes. That takes a big chunk out of it. As residents, you're kind of in some of the lower ranges for tax brackets, but you jump up really fast in this. If most surgeons will fall in that 35 to 37% tax bracket. It's big numbers that you're paying in taxes. A little bit about financial independence, because something you should be thinking about from day one, because a lot of you are coming out with debt from medical school that you carry through your residency and fellowship. The FIRE movement, which is FIRE, financial independence, retire early. It's a real good philosophy to really keep in mind. You got to start saving right now. You are already way behind. Some people call medical school the $1 million mistake. Your friends who have not gone to medical school and done residency and fellowship and 2 years of research, they've been putting away money for years. And financially, your friends who out of college went to work, they're $1 million ahead of you right now, even if they had a relatively modest paying job. Free yourself from debt as soon as possible. Time those loan repayments. Don't drag it out longer than you have to. Don't overinsure. People are going to come to you every which way with you're a doctor now and you need to have a lot of insurance and life insurance. People tend to get way overinsured on a variety of things. It's a big waste of money. You may want to have a financial advisor and definitely use an accountant at this point. Do not do this do taxes on your own if you're a physician. You're going to waste money. And then watch out for the bad doctor investments. You're sitting in the doctor's lounge between cases and someone talks to you about, I made all this money buying real estate in this town. Doctors always fall on, they feel that they're being left out and joining on bad investments all the time. I tell my accountant and I have a real good deal on, I don't prepare my taxes and my accountant doesn't take out his own appendix. So yes, I did take out my accountant's appendix. Control your expenses. It's real tempting to buy a big house and get a nice car as soon as you finish your fellowship. Put a little money away for yourself first. You can deal with not the biggest house and not the nicest car for the first couple years. This will make a big difference for you. And always maximize your retirement and tax benefits. You got to pay yourself first. Many of you will have a healthcare savings account. Use that to your advantage. It is a triple tax advantage way of putting away money for your future. Really important thing to think about. And then the power of compounding over time. Put away money a little bit at a time over many years. It will make a big difference. When you get to those times like I'm at with kids in college and medical school now, putting away money early makes it real easy to do later. Those are college savings plans if you have kids. So my final thoughts, do not choose your first or subsequent point based on compensation alone. You will not be happy. You can't compare with your friends, different locations, different pay. And what matters to me, the things that matter more than money is doing what I love to do at work. Mostly weekend rounding is never my thing. Dr. Wilson was one of my residents and yep, she knows about the rounding in my hospital. Teaching matters to me. Surrounding myself with good people matters, like this committee here. The culture of the organization I'm in matters. Things like skiing, boating, spend time with my family and friends, and security and stability matter. So for me, what matters the most is getting out to places like this, out to Utah to ski. So that's it for me, and I will stop my sharing. And I think we're gonna do some question and answers now.
So I should buy a vineyard, Darren. That was on my bucket list, but I heard that's the quickest way to make a millionaire out of a billionaire. That's what someone told me recently.
Darn it. I got really excited when you asked that question. So I'll just go for the bourbon distillery with you, Renee.
Yeah.
Sounds good.
Those were excellent.
Darren, sorry, I'll make a comment real quick before we get started, because what you said on that last slide, I think is probably deserves to be highlighted more than anything else we've said today, which is money is not everything. I have the two best partners on the entire planet. And who you work with and feeling valued and appreciated is so much more important than the dollar sign at the end of the day. You guys are all going to make a lot of money. You need a lot of money because you are in a lot of debt, unless you're, you guys were more fortunate than me and someone paid for everything. But I came out in a lot of debt. You're going to make a ton of money no matter where you go, but you really want to love your job. So I agree with what Darren said. I also will just add, ask. It never hurts to ask. And especially as a woman, I'm actually unique in that I negotiated two first contracts and I broke one. Because it was a really bad contract that I signed in residency with the stipend before I knew better. And that was a colossal mistake, which I could give an entire lecture on why you should not sign contracts as a third-year resident. But I asked for things that I was told we never do that. It's not part of the package. I asked for a lot of extras and they gave me every single one of them. So if you don't ask, you will not receive.
And what are those extras that you're referring to? Like what?
I wanted a sign-on bonus, which in most academic facilities is not done. But they recruited me really hard here because they had to have a bariatric director and they knew me and wanted me. And I knew I was breaking a contract and I had to pay back the stipend. So I told them, you have to give me a sign-on bonus, and this is what I want to help pay down. I wanted a down payment on a home and I wanted to break my other contract. And so they gave me a decent chunk of money that had I not asked for, I wouldn't have gotten it. And it was pretty significant. It was more than I made my entire year as a fellow. I'll put it that way.
Wow.
Well, you had some experience and some leverage. They were already kind of recruiting you and
Yeah, but I was right out of fellowship. This was my first job out of fellowship, but I knew that the place I was going to, they were pretty desperate. They were losing their bariatric director within a month.
wow.
So I think knowing the hospital situation is also important. I knew that they really
Yeah.
wanted a director. And again, I went to med school here, so I knew a lot of the people and I was a known entity. They knew that I was likely to stay in Georgia and that I was probably a long-term investment. So I do think some of those things also matter. Take advantage of mentors and connections. My mentor was here, and that's who was really pushing hard to get me back here because he knew that I would mentor young women going into surgery. And at the time, we had two females on faculty. And so that was a big part of my conversation is why are there only two females here? Again, I'm at Yale, very diverse, 50-50, like the tons of women for me to have as peers and as mentors. So I was a little nervous to come into a department. The then chair made the comment is 50% of my residents are females. If I don't get some females to start coming here, who will mentor them? And you should be the first. Help me change and lead this way. So there were a lot of appealing things about it, both sides. So
That's interesting. So and you had a particular value for that job. What should the fellows bring up in some of these interviews to make them seem more valuable? Is it the cases, hey, I'm willing to do bari and general surgery, or like these are the amount of cases I had in fellowship? How does one make a strong case for themselves out of fellowship? Because there are so many applying for the same jobs. How can you stand out?
Especially considering they don't have that experience that they can rely on.
I think
Darren,
the
you want to go
important part
first?
I think the important part today is that there are no better foregut surgeons than us bariatric surgeons. And that's really important. We are the people to go to for the paraesophageal hernias, the things that the emergency general surgery services really don't want to touch. Okay. Somehow if the stomach 1 inch into the chest, it's a panic mode for any other surgeon, but for us, it's routine every day. We have a very good understanding of the complexities of navigating both obesity medicines and surgery today, which I think is very important to provide that kind of stability. And there's just a lot of, we're the minimally invasive experts also. We know how to do things minimally invasive. And you'd be surprised, even today in 2025, you've got surgeons who are in practice that really are not very comfortable doing laparoscopic or minimally invasive surgery. And I don't have to tell this group here how important that is.
I would say too, as someone who's hiring right now. So when I came here, I was the only bariatric surgeon right out of fellowship. Fast forward 8 years, I've now hired four other surgeons, and I'm hiring my fifth partner next year. They've already given me another FTE. That's pretty rapid expansion of a section in today's climate. And part of that is because we've diversified ourselves. It's like Darren said, is there a bad gallbladder in the hospital that ACS doesn't want to touch? You know what? Pretty good at taking out gallbladders with the robot. That's a chip shot compared to a VBG to bypass conversion. I mean, it just is. So I think we have created a niche for ourselves here. We also deliver, and I think this comes from being a bariatric surgeon where people can shop and go elsewhere. I feel like our ability to market ourselves to our patients and deliver really high patient satisfying care is something that sometimes our ACS colleagues or general surgeons lack because they're used to the trauma mindset, and it's just different, right? Like how you do it. And so we joke that we're the hernia surgeon of the stars. Like every faculty member that gets a hernia here comes to us. And so that has made its way up to the C-suite. Like anyone in that C-suite that needs anything general surgery done, they're going to call me and ask, can one of your partners do that? I think that's one way you make yourself stand out, but it's also, we've proven even when bariatric surgery took a dip, because we are such good foregut surgeons and general surgeons, we have not been cut back. If, like I said, we're being allowed to expand. So when I look at hiring someone, like right now, I've got an FTE that's sitting out there that I haven't even posted yet because I don't need to. The market is so full of people looking for these jobs right now that I probably won't even need to post it because I'm going to have people that hear about it. Now everyone on this call is probably going to email me all these fellows. But what I'm looking at is a well-rounded surgeon. I don't want someone who's going to come into the interview and tell me, I want to work this day, this day, this day, and I want to do sleeves. Like, I'm not looking for a sleeve-a-thon surgeon. That does not appeal to me at all. I want someone who can demonstrate to me that they had a complex fellowship experience. I'm not going to ask you as a fellow to do complex conversions your first year, but I really don't want to be teaching you how to do a bypass either. And that's, you know, I've hired now two fellows straight out of fellowship to join me in practice. So I've mentored two people through that first year of practice, and I'm there for the first 10 bypasses no matter what. That's my promise to whoever I hire. You're not doing your first 10 bypasses without me in the room. I'm sorry if that annoys you. I have a program to protect. So I'm there, you do it, but I do think it also fosters independent growth and confidence. But I think you just need to market yourself as a good person who's willing to work hard and market that you can do more than just a sleeve. You're not just a sleeve surgeon, you're a foregut surgeon, a general surgeon, a bariatric surgeon, and then really make sure that you're joining a group where your mindset's the same as theirs. Like if this is a group that values family and skiing and boating, like I could go work in Darren's practice because I value all of those things. I'm not going to go work with a surgeon who expects me to bang out 12,000 RVUs a year. I have no interest whatsoever. I don't care if you want to pay me $1 million a year. I'm not doing 12,000 RVUs in a year. That is never going to appeal to me. I like doing other things too.
We got a question in the chat, I see.
Yeah.
Get
Philip,
to,
yeah, I can read that.
go ahead.
Philip says he's been undercompensated 70% of the state average for his tenure at his current employer, and he's currently in negotiations. What's reasonable to ask? He's tempted to ask for a number that would make up for being underpaid the last 3 years, but is that realistic?
No.
Well, that's actually a question that, that's a question that I have actually faced recently. I happen to have a role in the compensation committee at my healthcare system. Most healthcare systems will not, they can't put something in a contract in any way to make up for things in the past, for underpaid in the past. It's got to be based on, you're going to have a certain volume of cases that will support whatever that number is. Now, if you can justify that whatever it is that you're being paid is well under, then I think you have a good argument to come up to market value. But you got to, I think you got to consider the situation you're in. Are you in a position where you're willing to move somewhere else? Is there another healthcare system? Are you allowed to move based on your restrictive covenants? You know, sometimes they can have you kind of locked in there, and with that kind of gap, you may have to ask yourself, am I willing to walk away also? You know, and you know, when you're negotiating with a healthcare system, they don't like greedy surgeons. They really don't. They like happy surgeons. They like greedy surgeons. Now, I don't think it's being greedy asking to be paid for at least at market value. Okay. And this is something that I think especially applies to women that we have here. I think it's finally getting a lot better. I have a daughter going to medicine, so I'm especially sensitive to this topic. But you know, if you're being underpaid, you got to be careful there. You know, you got to ask, why am I being underpaid? And you know, but that's a good question when you're as a fellow looking at a first job. Find out, you know, how confident can I be that I'm going to be paid the same as all of my peers? I think it's really important to ask that question today. And I think most employers get very uncomfortable when they learn that there is a woman who's making less than me in the same position.
And I will tell you, as a woman who is a section chief, I had a very uncomfortable conversation this year with my chair. Most academic institutions publish salaries if you're a public, like a university employed physician. So I actually walked in with the salaries of every other male section chief. I'm the only female. And I showed the salary gap, and I was prepared to walk. So as Darren said, if you're not prepared to walk, don't walk in and make that statement. But um, he did appropriately compensate me. I got a significant raise. So I think if you can show that there are clear inequities based off gender, race, other things where there should not be salary inequities, that's big. It worked for me this past year. I think the other thing is you have to start somewhere good. I argue really hard for the base salary of all of my assistant professors coming into my section. Because once you have that starting salary, it's hard to get raises and move up. If you start $100,000 under where you probably should be, you're going to spend the first 10 years of your career making up that gap. So you need to make sure that your starting salary is fair. Now, at most major academic centers now, I will tell you there's a package for assistant professors. Like if you're coming in as an assistant professor, it's based off fair market value. That's what you're getting. It's the same as everyone else. There's very little wiggle room. Like I said, if you want to ask for certain things, you can. Like, hey, like I don't need a relocation bonus. I'd rather have that bonus to go towards loan debt. Can you not just pay for my relocation? We just had someone do that, and they did it. They just gave them a check. Instead of paying for their moving expenses, they said, okay, well, instead of your 15K to move, we'll just give you a check. And it worked. So there are certain things that are negotiable, but that starting pay is, man, that starting pay is hard to recover from if you accept a job that's
Yeah.
100K under where you should be starting. Don't make that mistake.
Yep.
Are
Yeah,
there
absolutely.
resources you guys recommend for fellows to use to make sure they're
Yeah.
coming in at market value?
ASMBS actually publishes every year that survey. Yeah, I mean, I would look at that thing. I took it. And that's the reason Teresa LeMasters, when they created this, that was the intent. It's not meant to be published on the website and, you know, blasted all over Twitter. It's meant to take to your C-suite and show this is what a bariatric surgeon in my community doing similar volumes as me makes, to give them a comparison. And that's available every single year. That's available through the ASMBS. It's specific. It's basically like your MGMA data, but for bariatric surgeons.
I think another thing to do is to talk to your fellowship director also. Your fellowship directors want you to be successful. It makes their fellowship program look good. Go back to people that you trusted in your residency, and talk to people and get that advice. And you know, I've done it before for you know, people that I've trained. Maybe for Rakisha, I think at one point, you know, they say, hey, how's it look in the contract? You know, how's it look in the contract? And it's okay to ask that. And I think the other thing you can use as a resource is, you know, be very open with the questions you ask when you're meeting with the administrative folks wherever you're interviewing. Because you're probably going to meet, if you're interviewing for a healthcare system or for an academic center, which are all essentially the same thing today. You know, while you're interviewing with those administration people, really ask the hard questions. You know, a question that I think is very important today is, you know, if a healthcare system is in desperate need to hire someone and they're going to be paying a little bit above market value, you know, for people that are already there, if someone new coming in gets paid more, that doesn't feel right. So sometimes healthcare systems do what they call equity adjustments. You know, if all of a sudden the new person that came in is at a higher salary, they got to bump everyone's salary up to be equal. Again, different organizations have different philosophies on this. They like to keep you in silos. They like to keep you apart and not talking to each other. So, you know, get that outside mentorship. I think it's the best thing you can do.
Yeah, I definitely had my fellowship director review my contract. As soon as I got it, I handed it to him and said, "Would you take this?" And he helped me pick apart some things that were good and some that were great, and ask that was valuable. You had it in one of your slides, Darren, but I want to make sure the fellows understand non-salaried benefits are huge. If you're looking at two jobs and one pays you 350 and one pays you 500, look a little bit closer. Is this job over here giving you tuition assistance for your kids to go to college? Is this job going to match? And what are they going to match your 401k at? Non-taxable salary benefits are huge, guys. Like, it's not, don't just look at the dollars. You got to look at these other things. Look at the healthcare plan. I will tell you, I think our chair does a really good job here, because he slides a sheet to you when you're in the last stages of your interview, and he says, this is the value of your non-taxable benefits. And for me, it was about $150,000 a year in non-taxable benefits if you maximized them. That's huge. Non-taxable.
The big thing there, because contracts, it'll be interesting, like the 401k match won't happen your first year. It may happen your second or your third or your fourth. That's all negotiable. You negotiate your salary, and then you negotiate your non-taxable taxable benefits. And it's to make sure you have fair market value. I do think one of the other parts of this that's really important, especially is like coming straight out of fellowship or being junior, is to the point Dr. Tishler brought up, is talking to your fellowship director and mentor, but practice the conversation. It is somewhat, none of us went into medicine to negotiate contracts. Many of us don't have the experience of negotiating contracts. And I'll tell you, my first contract negotiation was one of the most uncomfortable things I ever did. And I didn't want to do it. I dug my heels in. And my husband, and I'm going to give him credit where credit is due, forced me to do the research, reading a bunch of different resources. And to be fair, I learned a ton, and then took a leadership course that also taught me how to negotiate. And I feel like now my going into a couple contract negotiations and over the last 9.5 years, I feel so much more comfortable. It is not personal, it's professional, but practicing it makes it better. And it's something, kind of to Dr. Tischler's point, paying it forward is really helpful. So your
Yeah.
program directors will help. And if you're struggling to find somebody to help, this is where ASMBS has a mentorship program that can be helpful. And many of us on the call, reach out, happy to negotiate, happy to give you my resources. I have a list of books that I recommend everybody reading or audio listening to.
Same here,
I
Shaina. Again, I negotiated a horrible contract. I feel like I'm unique in that
Yeah.
I literally negotiated, and by negotiate, I mean I didn't negotiate at all. I signed a horrible contract as a third-year resident.
Yeah.
Awful. Worst contract I could have ever signed, and I was smart enough to break it. And that was hard because I felt disloyal. I felt so many dirty things. I was like, oh my gosh, like I'm a horrible human. This place has been counting on me. It was not the right professional move for me, and it would
Yeah.
have derailed my academic career. And it took a mentor telling me that. It took a mentor telling me and laying it out for me that it was a bad mistake, and I did not owe that healthcare system anything, that I needed to think about me and my family. And my husband also was like, what's wrong with you? Like, why are you not negotiating? I feel like
Yeah.
women we are worse at this than men for some reason.
There's
Um,
data on that, actually.
there is.
Yeah.
Yeah.
So I actually was very honest with the second negotiation. I didn't want to come across as greedy, so I just told him, I was like, I have a lot of loans. I'm the breadwinner for my family. I really need to make this amount of money, and I really need this for this. And I feel like that openness, it wasn't about greed. I wasn't going out to buy a Maserati. I wanted to protect my family, and I think that was appreciated.
Yeah.
Absolutely. And I think another aspect of it is, you know, you hear us talking about negotiations. Sometimes you go in to a job interview and you're finalizing it, and it's a mutually beneficial relationship. And sometimes it feels right, and you don't have to negotiate hard. And I think don't go into an interview or the negotiation process where it makes it sound like it's all about me. Yes, it is about you, but at the same time, spend more time talking about what you have to offer the employer, the healthcare system, the hospital, what your benefits are. I think it goes a lot better. Again, don't be afraid to be an advocate for yourself if it doesn't seem right. And like I said, you really can't compare any two jobs together unless it's you looking at both. So don't talk to your peers about what they're making, because there's just based on your location alone and the need for a surgeon. And we got to be realistic right now. Okay. Right now, this year, 2025, if you're looking for a position as a bariatric surgeon, a couple of years ago, I had a lot of trouble hiring a bariatric surgeon. Right now, I think I have no open positions in my healthcare system, but we have a lot of applicants coming through. So you got to be mindful. You got to read the room. Okay. Right now, I think hospitals and healthcare systems are in the driver's seat right now. In getting that first position is very important. But also be an advocate about why you believe that the GLP-1 revolution is not going to put us out of business. Okay. And have a good answer about that, because boy, if I'm hiring somebody, I want to hear about that. I really do. I want to hear about, because, I'm thinking of some of my own healthcare system, a leader who, comes from internal medicine and said, oh, come on, there's just a shot for that now. And every single day he says, can't believe you're still here. There's a shot for that now. And, you got to be ready for that.
Absolutely. I think we might need a part two, because there's so
Yeah.
much more to still discuss, but I love how y'all highlighted adding value and knowing your own value going into these negotiations, also educating yourself on your financial literacy. I was able to get debt-free in my second year of practice. I'm in my fourth year of practice now. No debt. And so I think all of the things are possible, having great partners, finding a great place. And yeah, please reach out to us for more resources, but we might really have to consider a part two or something else. But fantastic advice. Thank you both so much. And I think that's all the time we have. So everyone, enjoy your Friday, and we'll see you around, because this is your last month fellowship.
Shaina and Rakisha, thank you so much for letting me be part of this. I love the opportunity to engage with our fellows.
This was
We really
great,
appreciate it.
great talk. Love this.
Thank you guys so very much. This will be available on our ASMBS Fellow Project and Webinar website in the Learning Management System, so you can use it in the future. If you have questions, I know Dr. Hilton was very kind and put her information in the chat, but if you reach out to us as well. I know you guys have reached out to me in the past. We're always happy to answer questions. Happy Friday, guys, and enjoy the rest of your fellowship year, which is almost done.